Hello and welcome everybody to this edition of the MAND 2024 Northeast Coterie virtual sessions. If you don't know me already, you probably should if you've been watching all of these recordings and have attended any of the MAND continuing education conferences before. But I am Corey Marinero. I'm a naturopathic doctor, and today we're going to be talking about long COVID, one of my favorite things to discuss in my clinical practice, but also in education applications. And specifically, we're going to be talking about the plethora and variety of dysautonomia type presentations that can occur with long COVID and how to spot those in your patient cases, what mechanisms of action we can look at and examine and derive therapeutic applications from. So about me, I am the owner and medical director of New England Naturopathic Health, which was founded in 2012 in Waterville, Maine. I'm also the conference coordinator for the Northeast Coteries. I have no financial disclosures for today. My clinical interest in my practice, I have several, but essentially what they all boil down to is the individuality of our patients' immune systems. And so what's super interesting to me is how patients can express sort of their disease states in different ways and what the individuality of the immune response looks like. And boy, howdy, was COVID a really interesting opportunity to explore that for us as clinicians. Same infection, different presentations for everybody. And particularly when it comes to long COVID, the degree of the acute infection with COVID, the degree of the intensity of the original infection didn't really have a whole lot of bearing on how long COVID states showed up. So interesting stuff. And truthfully, a lot of the clinical thinking that I do has really been honed during since March of 2020, as I've been treating COVID patients and long COVID patients, really has awakened me to this sort of individuality of the immune responses as well as unnecessary inflammation. So what's the difference between a person that gets a COVID infection or any other type of infection, clears it out, no residual effects, and the person that gets maybe a mild, maybe a severe infection, but the infection stays around, or at least the immune response to the infection stays around. So we're going to make several arguments today that all of that is sort of baked into the immune system and what the patient brought with them into COVID. And so I like to think about my patients and their individual cases as sort of vessels, right? And I like to think of the bottom layer of the vessel being the patient's genetics. Much of the dysfunction of the immune system sort of built into those genetics. And then there's epigenetic stressors sort of turn on and express and cause the patient to express the vulnerabilities in their genes. And so on top of the genetics, we have, stuff that happens to us as children, childhood illness, childhood trauma, accidents of various sorts, injuries, etc. And then, and the things that are residual from those. And then on top of that, there's a layer of sort of the microbiome and chronic infections, dysfunction in the microbiome, chronic infections that we carry around with us that have influences on, our phenotype of how we express inflammation, how much stuff we're carrying around with us. And on top of that is sort of the environment that a person lives and works in and spends time in, and what's the air quality like, and how much toxin exposure are they having on a day-to-day basis, not just in terms of mycotoxins and kind of biochemical poisonous toxins, but also in terms of energetic toxicity, things like that, toxic relationships, chronic stressors. So all kind of lumped into, for me, the environment. On top of that is the lifestyle practices of the individual person. how tuned in they are to taking care of themselves, how tuned in they are to what their body needs, and how to make changes as appropriate. And so, you know, until the patient can't, until the patient does notice that their symptoms are spilling over from the cup, it's all sort of contained within this vessel. And so the reason that I really wanted to dive into this subject is because in the last, I don't know, 3 years, 4 years since March of 2020, there's been a whole bunch of new patient presentations in my practice. So patients that, would typically come up with the sort of chronic infections, chronic Lyme, mold illness, autoimmunity, things like that, are now coming up with more kind of postural orthostatic tachycardia syndromes, more neurological complaints, things that I had seen little glimpses of before, but never so concentrated in my patient population. And so wanting to, as always, sort of meet the needs of my patients, a deep dive into the literature of long COVID, and particularly neurological applications and how the autonomic nervous system is affected, is kind of indicated. And the way that I think about it is that for many, many people in the last 3 to 4 years, COVID or a spike protein injury is that kind of top layer that causes, kind of debilitating immune dysfunction to occur. So everything was going okay, though we did have all this stuff in the vessel until the infection came along, or the stimulus came along. It spills over, and now all of a sudden the person is incapacitated, or their quality of life is severely compromised. And so can we work within the layers of the vessel? Yes, we can. COVID is a really interesting example of an infection that doesn't really, though it's a viral infection, doesn't really care about antivirals, right? So we can't really just use antivirals to treat the infection. It's not going to go away that way. We have all the physiology that's now involved in the immune response. We have to figure out artful ways of getting it all back in the vessel. So top layer stuff here. So the technical definition of long COVID is post-acute sequelae of SARS-CoV-2, also known as PASC. It has its own ICD-10 code. And the technical definition is persistent clinical signs and symptoms that appear while or after suffering COVID-19, persist for 12 weeks, and cannot be explained by an alternative diagnosis. And our most common new onset conditions within this realm are cardiovascular, thrombotic, cerebrovascular disease, so compromised circulation to all these organs and the rest of our body. Type 2 diabetes, kind of an anomaly. We don't really think about it that way, but we'll explain why when we look at the autonomic nervous system and the effects that COVID has on it. Myalgic encephalitis, encephalomyelitis, chronic fatigue syndrome, and then the dysautonomia, especially POTS. And so POTS has really become, as we'll see, sort of this umbrella term for all of the things that could potentially go wrong in the neurological system after COVID. The incidence of long COVID is variable in terms of the stats. And so as you can see from my references, I did a very, very, very comprehensive exploration of the literature around this subject. And what I tried to do here in terms of the stats is give the low ball and the high ball figures that I could see. So estimates are 10 to 35% of people that have a COVID infection will go on to develop some sort of long COVID type pathology, one or more symptoms that last more than 12 weeks. And the incidence is much higher for hospitalized cases, probably because of some of the interventions and because of the deconditioning that occurs while a person's hospitalized. That's 50 to 84%. And then 10 to 35% of non-hospitalized cases. And then 10 to 12% of vaccinated cases. So those are people that have never had a documented COVID infection, and their symptoms came on soon after, and particularly the mRNA vaccinations. By the way, the pathology and the mechanisms of action sort of apply to both presentations, whether the original injury took place from a COVID infection or COVID vaccination. So we sort of lump the two together in terms of pathology. The largest meta-analysis that I could find of close to 50,000 COVID-19 survivors found that 80% of patients experience one or more long-term symptom 2 weeks to 110 days post-infection. Most common is fatigue. Then following that is headaches, 27% brain fog, cognitive impairment. So that's a quarter of people. Dyspnea is the next, tachycardia, palpitations, and then decreased exercise tolerance, something that you'll hear your COVID patients talk about a lot. And the literature, especially if you're just sort of starting to skim the surface on long COVID, is kind of hopeless, in terms of what answers there are out there for both clinicians and patients. And up to like 25, the stats are about 25% of patients with long COVID can't work. And so it's becoming this huge kind of impact on our both our economy, but also on our healthcare system of this population of patients, which is pretty significant, that is not well understood. And so, I always like to start, when I'm starting to research something, I like to start with the CDC, just sort of get the vocabulary down, the definitions, et cetera, et cetera. And when you go to the CDC website for long COVID, sort of guidance as a clinician, there's really not a whole lot there. Sort of the disclaimer is, all right, well, long COVID is kind of mysterious and we don't really understand it yet, and check back later for updates. So not a whole lot of answers out there, and really requires a sort of deep dive and combing through the literature. So essentially, no validated current effective treatment. So those of us that are treating COVID are sort of, pioneering our methodology ourselves. And so this was taken from a 2022 Brookings Institute article called "Is Long COVID Worsening the Labor Shortage?" I was just going to mention this as an aside, difficulty recovering, the economy having difficulty recovering from COVID, particularly in terms of workers. There's all these hypotheses about, well, people are lazy, or people got used to the extra money, people got used to not working, people have, can't go back to work because of childcare, people can't, there's all these things, but nobody talks about long COVID, and that's potentially a huge contributing factor. So from the same article, long COVID, just the stats that we know about, which is probably an underestimation, could be responsible for 15% of all unfilled jobs, which is a significant chunk. And so our technical definition of POTS, turning now to POTS, our technical definition of POTS came along just in time for the COVID pandemic. It was determined, actually written down in 2019 from this collaboration between the National Heart, Lung, and Blood Institute and the National Institute of Neurological Disorders and Stroke. So even in 2019, there was enough talk about this condition that the United States Congress actually directed these two organizations to come up with a technical definition. So it is technically a sustained heart rate increment increase of not less than 30 beats per minute within 10 minutes of standing or head up tilt. And for patients between 12 and 19, that has to be 40 beats per minute. There has to be a documented absence of orthostatic hypotension, meaning like the blood pressure doesn't necessarily drop in any measurable way permanently on standing. It's really this tachycardia presentation. Frequent symptoms include, the lightheadedness, palpitations, tremulousness, generalized weakness, blurred vision, and fatigue while the patient's standing. And then once they get recumbent again, there's relief of those symptoms. Duration of symptoms has to be at least 3 months. Has to be absence of other conditions that could explain it. And so that's a technical definition of POTS. What POTS has come to mean in the long COVID era, right? So about a year after this definition came out, is this kind of umbrella term that explains all of the things that can go wrong when the spike protein associated with the COVID-19 virus binds to the ACE2 receptor, so the angiotensin converting enzyme 2 receptor, and the feedback mechanisms that that has to our, and the implications that that has for the autonomic nervous system. And so the autonomic nervous system dysfunction is thought to arise from that binding. And so the ACE2 receptor is expressed throughout the body. Vital organs, many, many vital organs express it: the brain, the heart, the kidneys, the pancreas, right? So back to that new onset of type 2 diabetes that can take place during COVID, it's because the pancreas expresses receptors for the ACE2, or expresses ACE2 receptors. Immune cells, macrophages, astrocytes, gliocytes, mast cells all express ACE2 receptors, right? So they're all could be potentially targets for COVID. The cranial nerves, olfactory nerve 1, olfactory nerve 5, or sorry, cranial nerve 5, the trigeminal nerve, and the vagus nerve, which we'll talk a lot about in the upcoming slides. So all of these are potential targets for COVID and also for the immune response that comes with the viral invasion of those tissues. And so back to a little review of our angiotensin, renin-angiotensin aldosterone system. Those of you who went to Bastyr and were lucky enough to have Dr. Harold Modell for physiology will remember this from the toilet analogy and the plumbing system in your house analogy. Thanks, Dr. Modell, up there watching over us, for giving us that reference point. We'll never forget it. So angiotensin. Angiotensin comes from the liver, and then is converted to angiotensin 1 by renin, and then angiotensin 2 via ACE, the angiotensin converting enzyme. And then once it is angiotensin 2 binds to our ACE2 receptor, then that is going to cause us to have increased sympathetic outflow, aldosterone synthesis, increased catecholamine release from the adrenal glands. It's going to have us do sodium retention through the kidneys, and antidiuretic hormone release so we can conserve water, and it's going to cause ultimately vasoconstriction. And that's what this system is trying to do. And so this graphic essentially, I'm going to move myself here so you guys can see this. This graphic essentially shows us SARS-CoV-2 binding at the ACE2 receptor, getting into the cell, and eventually releasing outside of the cell, the now destroyed, defunct cell, COVID-19 viruses. And so these are all of the places that express ACE2 receptors that COVID can bind. So in the heart, the effects can potentially be edema, inflammatory infiltrates, atrophy of the cardiac muscle fibers, in the lungs, pneumonia, edema, inflammatory infiltrates, fibrosis, mucus, and fluids. In the gut, colon damage, colitis, ulcers, diarrhea. In the brain, edema, degeneration of neurons, ataxia, headache, loss of smell and taste, acute renal impairment, high blood and urea nitrogen and creatinine, and then in the eyes, conjunctivitis, and a few other things in the eyes. These are things that you see quite commonly in your long COVID patients and in the acute, particularly with the lungs and the acute presentations. And so our mechanisms of neuroinvasion via the ACE2 receptor, at least, the COVID can bind, can invade via the olfactory epithelium, and that's where the virus can initially enter the body. That's where the initial immune response takes place, and that's typically why people will lose their sense of smell and taste there. Okay, so it can go into the olfactory epithelium and enter via cranial nerve 1 to the brain. It can also enter via transsynaptic route from particularly the vagus nerve and also the trigeminal nerve. And so kind of following that nerve back, those nerves back up to the brain. Hematogenic route the virus can actually penetrate the epithelia of the blood vessels, the endothelium of the blood vessels, and go into various tissues there. And my favorite mechanism that COVID utilizes to eventually get up to the brain and cause neurologic damage is this leukocytic route. So the Trojan horse mechanism, because macrophages and gliocytes and astrocytes and mast cells express ACE2 receptors, they can, an infected macrophage or other immune sentinel like this can cross the blood-brain barrier, bring the virus in that way. And that's how the virus gains access to the brain, where it can now cause neurologic damage. And so brainstem invasion through olfactory nerve 1 was really super big problem initially in the acute COVID infections that were sort of like life and death in the balance. Initially back in March of 2020. And essentially the virus persists and kind of gets into the brain through various mechanisms that we just looked at. And once it's there in the brainstem, where a lot of our autonomic functions take place, the medulla oblongata at the mucosal neuronal junction, contains our cardiovascular and respiratory centers. So when people were just stopping breathing and their hearts were stopping, it wasn't necessarily because there was something happening in the heart or the lungs. It was because COVID was actually invading the brainstem and invading those neurologic centers that control those autonomic nervous system functions. So that's the acute, really severe fatal presentation that was such a problem in the beginning of COVID. Now, more mild presentations, but still those autonomic nervous systems are affected. And you'll hear some of your long COVID patients talking about, like, I have to think about it. I have to really focus my energy to breathe, or I really have to focus my energy on what my heart's doing, or awareness of what my heart's doing. So, interesting stuff in terms of what we think of as pathology is native to the organ, but really can be happening at the brainstem. And so our autonomic dysfunction symptoms in COVID, what's known as POTS, but can be really so much more. 2 to 14% of the general population of COVID survivors meet the clinical criteria for POTS, 22% of patients with symptoms indicating autonomic dysfunction, 31 of those reporting tachycardia, and 75% with cardiovascular complaints and orthostatic intolerance. So quite a large population. And so our symptoms that we would typically associate with POTS: lightheadedness, dizziness, palpitations, pre-syncope. Actual syncope is rare, and if there is syncope, you want to be thinking about other diagnoses: weakness and heaviness in the limbs, tremulousness, shortness of breath, chest pain, and the degree of functional impairment can approach that of CHF, or congestive heart failure, and chronic obstructive pulmonary disease. And so there's this definition of POTS, which then now is going to become an umbrella term for all of the things that can go wrong in long COVID. So, but wait, there's more. POTS plus. So this is orthostatic symptoms, POTS, in addition to, now we start to rope in other body systems that have to do with the autonomic nervous system: gastric emptying disorders, severe constipation or diarrhea, neurogenic incontinence, so getting into the bladder, severe chronic pain, joint hypermobility. So now we're starting to rope in our EDS type pathologies, intractable headaches. So now we're starting to rope in migraines into this pathology, and anaphylactic symptoms, food intolerances. And so we're starting to get into our mast cell activation type pathologies, neurological sensory symptoms. And there's even more on top of that now that we're in the long COVID era. So now there's long COVID POTS. And so that is orthostatic tachycardia, our typical POTS symptoms, more than 12 weeks post-infection. Plus, we've also got, earaches, peripheral neuropathy, sleep disturbance, cognitive impairment, skin rashes, anxiety, depression, sore throat, headache, tinnitus, nausea, diarrhea, joint muscle pain, pretty much anything that you can think of that can go wrong with the body can be now lumped under this thing of long COVID POTS. And so there's probably more at stake here or more at play here than just POTS, right? But we start to wonder, like, what are the other eclipsing body systems that are being affected, and how does it relate back to our autonomic nervous system? So you can picture these poor patients that have these symptoms and are just getting referred around to different specialists, and nobody's really connecting the dots as to what's going on here and the underlying causes. And so, tends to be a pretty hopeless situation for these patients. Other clinical features, generally, these people are women, 5-to-1 ratio, female to male. They're about 30 years old at the age of onset. That's all kind of different now, now in the era of COVID. There's clinical overlap with all of the things that we'll talk about: EDS, MCAS, rheumatoid arthritis, Hashimoto's thyroiditis, celiac IBS, all sort of on the autoimmune kind of side of things, unnecessary inflammatory kind of side of things. The onset and episodes precipitated by heat, exercise, postprandial state. That is a really, really good clue for you when people talk about they have symptoms after eating, not just on standing, but after eating. And that's because of venous pooling in the splanchnic veins that supply the gut and arteries. And that is, the reason that the brain can't get circulation at that point, because all the blood's in the gut after we eat. Trauma, pregnancy, surgery, premenstrual state. Many, many women will talk about their symptoms being aggravated in the premenstrual state. Okay? And that goes beyond just estrogen dominance, right? At that point, you're talking about histamine kind of creeping in there too, and other inflammatory things. Can be precipitated by multiple infections: COVID, EBV, Borrelia, influenza. Gastroenteritis, interestingly, is a precipitating factor for a lot of people for POTS. Other factors, lower income, inability to rest, type 2 diabetes, people that have already struggled with reactivating EBV and are just sort of prone to viral things, connective tissue disorders, ADHD, the chronic urticaria and allergic rhinitis of mast cell disorders. But interestingly, no reported pre-existing conditions in a third of long COVID sufferers. I don't know. I have a hard time believing that. I have had multiple patients with long COVID tell me that they never had a health problem before until they got to long COVID. And I feel like that's because things are very normalized, right? There are plenty of people that have horrible, awful IBS, but have just been told that that's normal. There are plenty of people that have horrible, awful allergies that they have to take, some sort of H1 blocker for every day. That's normal, right? It's not seen as pathology. And so once you start asking people, or, for women, they have a history of migraines, or they have a history of, menstrual disorders, that's all normal, right? Or considered to be normal. And so once you start asking the right questions, you do see that people are carrying these things with them into the COVID infection, right? And that top layer is what's causing the spillover. And so when we say the dreaded triad, this is the dreaded triad that I like to think of as the hypermobility, Ehlers-Danlos syndrome, hypermobile Ehlers-Danlos syndrome, POTS, and MCAS. The reason that it is the dreaded triad from my perspective is because really, generally people will express one of these more than the other, and you'll see that play out in the types of long COVID patients that we'll talk about later. But you'll see this. You'll see like one set of symptoms forward, right? They have more of a cardiovascular presentation, or they have more of a hypermobile presentation, or even more of an allergic presentation. But really, all of these mechanisms of action are at play here. And you sort of have to think of it not as any one pathology, but inflammatory, I'm sorry about that, thumbs up, but as inflammatory symptoms presenting in kind of overlapping ways, right? And so there's danger in relegating patients to any one of these because they all are really overlapping, and so are the mechanisms of action that perpetrate them. And so the COVID stimuli really are sort of like the cherry on top of this dreaded triad that sort of tend to bring all of these symptoms really to the surface for those that have it sort of baked into their genetics. And so there's lots of clinical overlap with post-long COVID POTS and EDS. EDS, as we know, hypermobility, skin hypersensibility, and tissue fragility has, same basically comorbidities as long COVID. The genetic vulnerabilities to tissue laxity, as we're going to see on the next slide, are common, right, between long COVID, POTS, and EDS. So it tells you that there's similar mechanisms of action at play here. In EDS specifically, there's tissue laxity, frequent injury, detrimental effects of literally gravity on the tissues. Literally, gravity is often too heavy for these people. There's earlier osteoarthritis due to excessive wear and tear in the joints, and there's tissue laxity that tends to lead to venous pooling and then triggers all the POTS type stuff, right? And with the POTS type stuff, we get this sympathetic activation, and we get a parasympathetic withdrawal. And so it frequently presents with this sort of like anxiety, GI dysfunction. So we can see how all of these conditions sort of overlap together. This article is really interesting, and I love when authors are kind of show a little bit of their personality in their work. This Dr. Golder Wilson basically took a whole bunch of long COVID patients and a whole bunch of POTS patients, did an analysis of their genetics, targeted specific genetics. And so the genetics are what he's calling the gene network, the rhizome of this tree. And then the pathophysiologic mechanisms, which is the trunk of this tree. And then up here is the symptoms, right? So it's a finding pattern of the canopy. And he compares his findings and uses this graphic in reference to the Ents, which are the tall sort of walking trees that help out Frodo in The Lord of the Rings. So props to you, Dr. Wilson. When you're reading 80 billion papers, it's really nice to have a little entertainment in there. So anyway, if you're interested, this is a great study. You can find the reference in the resources at the end. And so with EDS, now we have to start considering the clinical overlap into MCAS, and that's sort of what gets us closer to understanding about long COVID. Let me just move myself here. Okay. So 23% of long COVID patients develop a connective tissue disorder. Okay, so that kind of begs the question. Is EDS ever just EDS? Or is it a symptomatic state and tissue damage that is caused by an immunologic threat or an immunologic response? And if we're going to ask that question, we're going to have to ask, okay, how does tissue remodeling occur under the influence of the immune system, if it is indeed an immunologic response that has its vulnerabilities sort of included in the genetics? And so that is what takes us to my favorite thing to talk about, which is mast cell activation syndrome. And so mast cells express lots and lots of things that have, destructive effect on tissues and also proliferative effect on tissues. We'll take a little bit of a closer look at that in the following slides. But anyway, lead to tissue remodeling. And so mast cell activation has an estimated prevalence of 17% in the general population. That's a big chunk, almost 1 in 5. And those are the people that have allergies that they have to medicate on a day-to-day basis generally, or eczema or psoriasis or something along those lines. And then if you start asking them questions beyond whatever their atopic complaints are, and the asthma, the eczema, the allergies, if you start asking them questions about, headaches or menstrual cycles or, their gut, you're going to see a whole bunch of other inflammatory stuff come up in their symptom picture. Right? And so mast cell activation largely responsible for a lot of that. And so the neuroinflammatory symptoms can be really forward in the mast cell activation people simply because mast cells have such massive influence on the blood-brain barrier, which you're about to see. And so mast cells really, they mean well, right? They can communicate. They could be, in theory, a very useful effector of the rest of the immune system. So look at all of the things that they can communicate with. They can communicate with smooth muscle by through angiotensin 2, substance P, histamine, and leukotrienes to cause contraction of the smooth muscle. And that is ostensibly to be able to purge whatever pathogen is going on there. They can interact with fibroblasts for tissue remodeling and repair processes, right? So that's really good in theory, except for when that mast cell is overstimulated, excuse me. They can have influence on neuronal cells, increasing pain perception, and that's to draw attention to the area that is affected by whatever invading mechanism is happening. And that's done through prostaglandin, substance P, inflammatory things that serve a purpose, but in the ongoing presentation of mast cell activation, tend to serve a dysfunctional type purpose. So that's just a few examples. Epithelial cells, they can communicate via proteases, histamines, interleukins, and 5-HT is precursor to serotonin, and can have these effects on electrolyte and mucus production and increased permeability of epithelial cells. That comes into play quite a bit at the blood-brain barrier. And so, basically they can communicate with every other cell that is involved in the immune response, right, and have pro-inflammatory influences. They mean well, right? And it's when mast cells get carried away, as in the modern, more complicated human that has a whole bunch of toxins and sort of industrial era poisons in their system. The mast cells are really irritated, and sort of there's this ongoing stimulation that is unnecessary of the rest of the immune cells. We start to see not so useful effects. And so, for instance, because of the way that mast cells can affect blood vessels, we're going to get this predisposition towards POTS, or the postural orthotachycardia syndrome, because the effects on the blood vessel itself can lead to laxity. We can get this sort of IgE-mediated autoimmune type presentations, leading to our more severe autoimmune presentations, rheumatoid arthritis, systemic lupus. And by the way, the rheumatoid arthritis also to do with the fibroblasts over here. So we can get fibroblast proliferation because the mast cell's ability to communicate with fibroblasts and overstimulate them, leading to a lot of our cases of chronic rhinitis, sinusitis, because there's too much tissue here, migraine headaches that start here. The classic sort of deviated septum that you hear about from every ENT ever that receives a complicated sinusitis patient is going to say you have a deviated septum, but they're not really going to ask why, even if there's no injury. So anyway, I think we all get what I'm talking about here. The nerve cell activation leads to sort of peripheral neuropathy, headaches, et cetera, et cetera. And so mast cell activation with COVID on top of it. So these are people that are already prone towards mast cell activation. You give them a good case of COVID, and we're going to get massive effects on the blood-brain barrier and blood-brain barrier integrity, and which will lead to our neuroinflammatory type presentations and actual damage to the brain. So mast cells are situated along mucosal cells, including the olfactory epithelia and the meninges on the brain side of the blood-brain barrier. And so in this position, they have all this access to all of the other immune sentinels that then can travel around the brain and the blood vessels, right? And so they can also participate, like we said, in this Trojan horse type mechanism because they can cause, because they have interest in wanting to affect the renin-angiotensin-aldosterone system. They express ACE2 receptors. So COVID can actually bind to them and change their behavior. And so when mast cells are activated, they release cytokines, they release histamine, serotonin, they release heparin, they release chondroitins, they release renin, angiotensin 2, they release proteases, they release all kinds of interesting stuff, including platelet aggregation factor. And so a lot of this is responsible for like tissue destruction, tissue remodeling, hypercoagulation, a whole bunch of things that we see as problematic in long COVID that we'll talk about here. And so this graphic is sort of just meant to represent sort of all of the things that mast cells can do at a blood-brain barrier neurovascular unit, essentially leading to sort of edema, leakiness of the blood-brain barrier, potential now for things that shouldn't be crossing the blood-brain barrier to cross, right? And all of the inflammatory things that come along with it. And so the inherent problem with people in general, regardless of what's causing it, with neuroinflammation that is physiologic in nature, is that they are often relegated to this population of people that are just crazy. And so they'll get a DSM diagnosis and they will get treated as if their only issue is a psychiatric issue. And of course, you're not going to be able to control this person's symptoms with just a psychiatric medication because you're not really going to affect the actual pathology of what's going on here, the physiology of what's going on here, if you're just looking at the depression or the anxiety or the OCD or whatever it is. So 4 in 5 patients are diagnosed with psychiatric conditions before being diagnosed with post-COVID POTS, and only 37% go on to retain the original diagnosis. And so this article, if you're interested in functional psychiatry, which I am very interested in this, if you're interested in this kind of approach to psychiatry, I highly recommend you reading this article. So this is a retrospective study of patients that had multiple institutionalizations, multiple interventions of psychiatric nature because of suicidality and extreme psychiatric symptoms, and that were refractory to treatment. Their symptoms were refractory to treatment with your standard psychiatric medications, and so they were treated as mast cell patients. And following a small cohort of patients, but through complete regression of their symptoms, simply by treating their mast cells, stabilizing mast cells in pharmaceutical ways. So I love this paragraph, and it speaks so true to our patient population so often. The mislabeling of these patients with psychiatric illness as a cause for systemic illness often leads to inappropriate or misdirected treatment, iatrogenic adverse events, resentment, mistrust on the part of the patient, doctor shopping, non-compliance, medical care avoidance, and psychological symptoms and trauma caused by their negative health experience with the healthcare system. Well, yeah, I mean, that's a lot of the patients that we see as naturopathic doctors, or at least that's a lot of the patients I see. And it's really pretty terrible, right? And so anyway, my goal in putting this up here is that if you've got a patient that is presenting as kind of difficult, angry, mistrustful, et cetera, there's good reasons for that. B, consider neuroinflammation in your differential diagnosis and consider what's happening on a physiologic level. So another problem with our COVID invasion is that the spike protein itself really loves the nicotinic acetylcholine receptor. And much of the new information that's coming out around potential COVID treatments, long COVID treatments, is around dislodging the spike protein from the nicotinic acetylcholine receptor. So we'll see some potential therapeutic treatments there in a bit. So there's emerging evidence of the cholinergic dysfunction, i.e. the ability of the brain to coordinate movement, both of the motor system and also the autonomic system, linked with spike protein affinity for nicotinic acetylcholine receptors. And so this receptor is responsible for sort of the coordinated actions of the brain. And so it mediates synaptic transmission of both the central nervous system, peripheral nervous system via acetylcholine. There is also this huge anti-inflammatory influence on the overall immune presentation or the immune activity that is mediated by this receptor. And so it attenuates macrophage-mediated cytokine production and therefore sort of minimizes the tissue injury that can result from the inflammatory response. By the way, just to like highlight the seriousness of what it's like when this receptor is affected, the other toxins that bind to this receptor include cobra venom and rabies viruses. So that's the extent of the damage that we can produce by binding to this receptor for the nervous system, right? It's pretty big, potentially fatal. So there's multiple emerging hypotheses around this interfering with that spike protein that's locked on to the NACH receptor, and many of those have to do with nicotine. And so you will hear about this a lot, I'm quite sure, in the coming years around long COVID. We'll talk more about it. And so the importance of the NACH receptor, just a little bit further information, essentially coordinates the autonomic nervous system response to internal and external stimuli, pretty important, mediating the changes that are necessary to take place. So a lot of our temperature regulation issues we'll see come out here. Involved in learning processes, neuronal development, synaptic plasticity, so that brain fog and the inability to retain information that people talk about can somewhat be attributed to this receptor being affected. It also increases release of neurotransmitters, including GABA and dopamine, making it a really attractive target for intervention in these patients. So there are three sort of case presentations, major case presentations. These are loose categories that I tend to think of in my own clinical opinion when it comes to my long COVID patients. So in other words, when I'm sitting with a new patient that has come to me specifically for long COVID, because the symptoms are so variable and they present different for everybody, I try to, in my clinical thinking, this is purely my clinical thinking, it's a disclaimer there, divide them into categories, right? And that's based on whatever symptoms are forward. Obviously, they overlap. Obviously, it's not super discrete in terms of what category they fall into. But, I'm always sort of looking for is what symptoms are forward, and that kind of tells me what mechanisms of action do I need to put into play. And I've listed these from easiest to hardest, right? In my own clinical opinion. And so this is where we sort of depart from literature review and into, my clinical thinking, though the interventions that I'm going to mention are backed up and cited in the literature. So three types of patients. Very, very tired patient. The classic sort of chronic fatigue syndrome patient that, naturopathic doctors have been treating for years. And that's the myalgic encephalomyelitis and chronic fatigue syndrome. Then the hypovolemic adrenergic overdrive patient, that's the classic sort of POTS EDS presentation with COVID on top of it. And then lastly, my favorite, the ongoing neurotropism. Neurotropism means ongoing viral invasion. Can't clear the virus due to inappropriate immune response, and that's the mast cell active patient. So the first one How to spot very, very tired patient. So the symptoms forward, the prominent symptoms are fatigue and brain fog. This is a person that is so tired they can't get out of their own way. They're generally, not always, but generally going to have circulation deficiencies or an overclotting history. DVTs, pulmonary embolisms, transient ischemic attacks. And they often will have overt signs of poor circulation, right? So they'll have sort of fluctuating, particularly with exercise or with any stimulus to the cardiovascular system. These are the patients that we'll talk about. They get discolorations, Raynaud's, et cetera, when circulation is stimulated. They often will have cold hands and feet for lots of reasons. Muscle weakness and muscle pain because of lactic acid buildup, because mitochondria not functioning. We'll talk more about that. These people can sleep. They can sleep and sleep and sleep, but they're never rested. Right? They never feel rested. They never feel like their sleep is efficient. And these are the patients that are real challenged in like kind of getting it together outside of necessities of survival. So they can like get themselves, showered and dressed and out the door in the morning and like do their work and take care of their family, but they can't keep track of things outside of that. So these are the patients that need frequent reminders to do what you're asking them to do. And you can tell, one of the ways that you can tell they're getting better is because they get better at doing the things that you're asking them to do once their tissue function improves. So our treatment goals for the very, very tired patient is essentially going to revolve around getting their mitochondria working. So we want to clean up mitochondrial function by encouraging our redox reactions. We want to supply the mitochondria with nutrients. We want to reperfuse the tissues by dissolving microclots and discouraging endothelial inflammation. And we want to jumpstart production of ATP. Those are essentially the goals. I really love this picture, so that's why I included it. But I also think it highlights like always be thinking about the mitochondria. Always, 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 particularly in brain stuff. Always be thinking about the mitochondria. So essentially with COVID infection, one thing that's universal is that there is this recruitment of the mitochondria to produce reactive oxygen species in the initial immune response. The persistence of the virus, depending on how long it lasts, will encourage that ongoing sort of diversion of energy from ATP production over to our reactive oxygen species as part of the immune response. The longer that goes on, the more we're going to have not ATP production happening because our energy is being invested in reactive oxygen species and immune signaling. And the more kind of depletion of redox we're going to have because that's going to suck up all of our redox nutrients. And the more, the more difficult it's going to be to recover from this state because we're actually causing tissue damage at that point, right, with our reactive oxygen species in an effort to get rid of the virus. But also we're going to beat up other parts of our cells, including the mitochondria itself. So this is all tied into that cell danger response that is a super important concept for us. So this is particularly true of the brain because the brain is so reliant on the mitochondrial function. So, again, mitochondrial function, super important. And so our mitochondrial function can also be compromised because of poor perfusion. And so it is a very, very large problem for people with COVID, long COVID, that they have these sort of microclotting tendencies. And so it's for lots and lots of reasons, but tends to make it so that tissue is dysfunctional, the muscles, the nervous system, et cetera, because there's just not enough blood getting to where it needs to go. And you can see that kind of overtly in circulation difficulties. But, really it's because of this microclotting that takes place that's going to shut down our perfusion of these tissues and our flow of nutrients to our mitochondria. So the hypercoagulation state can potentially continue as part of the long COVID pathologies, and is stimulated by any remnants of viral particles, and also low glutathione levels also encourages this. So glutathione is, of course, used up in that initial reactive oxygen species sort of immune response. So micro-level clots within small vessels and capillaries causes this reduced flow to organs and neurons. And so we have not necessarily like large impactful infarcts that we can see, but many small infarcts affecting our tissue function. And so mitochondria don't have enough sufficient oxygen because you're not getting enough blood flow. They don't have enough nutrients because you're not getting enough blood flow. They might still be focused on waging immunologic war. And so our ATP function or ATP production going to be seriously compromised. And so this is just a graphic of how the spike protein stimulates this clotting. Mast cells are right in there. And so we get, because of these fibrin amyloid microclots, we get destruction of blood-brain barrier and other membranes, leading to brain fog. We get low oxygen carrying capacity. And that's going to lead us to tissue dysfunction, and that's going to lead us to, all of these types of phenomena and cellular dysfunction, including mitochondria. So one of the things that has been really useful for these patients in my experience is nattokinase. So nattokinase is found in natto. It's a traditional Japanese food that's created by fermenting soybeans and uses the microorganism Bacillus subtilis. And so it is an inactivator. Its mechanisms of action are it inactivates plasminogen activator inhibitor 1. It's a lot of double negatives there, but essentially, discourages the formation of further clots. It increases fibrinolysis, so it can break up clots that are already there, and it decreases plasma levels of fibrinogen, various clotting factors, and various cytokines. And according to this article that I read on nattokinase, it has the highest clot dissolving potency among natural anticoagulants. It also has good, decent ability to degrade spike protein. And so that kind of makes it like a bonus feature here. For our patients that have cardiovascular disease or diabetes that are already going to be prone to these sort of hypercoagulation states, nattokinase also has this ability to sort of break up endothelial inflammation beyond the cholesterol, so it can help out with the things that conventional docs are trying to do with statins and things like that. It's anti-atherosclerotic, lipid lowering, antihypertensive, antithrombotic, neuroprotective. So great thing to use for patients who are tolerant of it. Most of them are. Because digestive enzyme has to be taken away from foods, the doses that I tend to use 100 to 200 milligrams QD once a day, twice a day. However often your patient can get this in on an empty stomach can be challenging for the patients that can't keep track of things to get it in on an empty stomach, right? That tends to be a big challenge. So our glutathione, really important in these people, right? Really does a lot, checks a lot of boxes in terms of mechanisms of actions that we're looking for. So glutathione initially depleted due to the reactive oxygen species production. And then low glutathione associated with a whole bunch of stuff like not being able to properly repair and transcribe our DNA, so difficult to make new healthy tissue. It's a risk factor for oxidative damage and immunothrombosis, low glutathione. And so we love glutathione because it sort of helps to buffer us, protect us from these mechanisms of action. And we know if there's been an immune response where the mitochondria has kicked over into reactive oxygen species production, we're going to have to replete that glutathione. Like a liposomal form for glutathione, 100 to 400 milligrams every day in divided doses. And we have to have caution with suspected heavy toxin load. So I tend to go light with the patients that I suspect have, heavy metals or mold toxicity or something like that, where that's a layer that we're looking at, because you can unintentionally kick on detoxification. It's generally not what this person needs at this point, right? That's for kind of later on down the road when they're more stable. I also love alpha lipoic acid in this patient population because it has ability to restore endothelial and vascular dysfunction by restoring nitric oxide synthase or activity. Again, just like our nattokinase, very helpful for patients that have CVD, cardiovascular disease, or diabetes. It interferes with oxidative stress by scavenging our reactive oxygen species. It inhibits NF-kappa B, and it regenerates our endogenous antioxidants. So in that way, it really is helpful for like supporting glutathione as well. 100 to 300 milligrams once or twice daily, and it has to be taken away from any therapeutic metals that you're using, like zinc or copper or iron, because it's heavy metal chelator. So it will chelate those. And so because heavy metal chelator also is a pretty decent biofilm disruptor, and biofilm disrupting products will frequently contain ALA. And so again, in the interest of not making an already very sick patient more sick by disrupting their biofilms or accidentally chelating them, in these patients that are severely compromised in terms of their quality of life, you just keep your dosing low, go low, slow, and put your other projects that you want to do with them kind of later on down the line once they're more stable. ALA has some useful, unlike some of these other nutrients, has some very useful foods that patients can get it in. So particularly organ meats, red meats and organ meats, if your patients are into that sort of thing. But also some vegetarian foods, the spinach, the tomatoes, chives, leeks, yeast, though I'm not a huge fan of giving people overtly yeast, but some people are. The other tool that I really love in this patient population to restore mitochondrial function is methylene blue. And so methylene blue has some really nice anti-inflammatory actions that it can do. But it also, primarily in this patient population, we're looking to kick on mitochondrial function, ATP production. It has this ability to shunt electrons from complex 1 to complex 3 of the respiratory chain. And so it avoids leakage of electrons at complexes 1 and 3, which are the primary sources of reactive oxygen species production. So sort of inhibits further reactive oxygen species production in an ongoing, sort of cell danger response. The conservation of electrons, of course, leads to increased cellular respiration, which is a beautiful thing. And so essentially this diagram shows how methylene blue shunts via its reduced state, leuco-MB, leucomethylene blue, shunts electrons from complex 1 to complex 4. So I'm sorry, that was a typo in the last slide. Complex 1 to complex 4, avoiding leakage at complex 3. And so this is also the population that benefits, in my experience, most from oxygen therapies. And there's great studies here. It was sort of too exhaustive to dive into specifically, but it makes sense that when the mitochondrial function is compromised, that you want to figure out artful ways to get oxygen to those mitochondria, to disrupt that sort of like anaerobic kind of state that they're in. Oxygen therapies can be either ozone or HBOT. The ozone uses the kinetic energy of the ozone molecule to penetrate through lipid barriers and get into the cell. Hyperbaric oxygen, of course, uses pressure. Similar mechanisms of action, and very, very useful therapies in these patients. And so if you're interested in the mechanisms of action and, all of the studies, you've got your references there. Use these if you have access to them. And so our clinical takeaways for the very, very tired patient. Essentially, this is your classic chronic fatigue syndrome patient, right? Same mechanisms of action. Our post-viral patient, right? The classic post-viral patient. Epstein-Barr virus was what we used to talk about. Now it's COVID. So more concentrated in the last 3 to 4 years because of COVID. We want to restore perfusion of tissues by dissolving microclots and endothelial inflammation. We can use nattokinase or lumbrokinase per your preference, glutathione, etc. We want to feed our mitochondria with whatever you would regularly use to feed mitochondria. Just make sure that the gut is working and that the patient's absorbing these things. We want to ensure adequate sleep, adequate calorie intake for these patients, right? They need to rest, they need lots of nutrients, they need to feed their cells. And these are the patients that tend to go off the rails in terms of their adrenal function, not producing enough cortisol, but also their thyroid function. And so be keeping an eye on those things, right? Often there's good reasons these patients are tired. They're not making cortisol, they're not making thyroid hormone, or both. And generally both need to be supported together. Correct them as necessary, monitor for them, correct them as necessary. And then also this population is the population that will sort of take this precipitous nosedive into menopause. And so because sort of all the endocrine resources are being used up, trying to run the body quickly runs out of resources to make particularly estrogen. Progesterone is usually already declined if the patient's anywhere near menopause. And so, these are the patients that you have to watch them, because if they do a precipitous nosedive into menopause, it makes all of these cognitive symptoms way, way worse, right? And so we just have to be monitoring for the signs and symptoms of menopause, rapid onset menopause especially. So our next patient type, hypovolemic adrenergic overdrive patient. This is your classic POTS/EDS patient. And so these are the people that will have that, maybe a little bit of that in their history. How to spot them? They have the classic POTS symptoms that we talked about, orthostatic phenomena. They have generally poorly understood cardiovascular phenomena. So these are people that have diagnoses like AFib or supraventricular tachycardia or hypertension that nobody understands because there's no cardiovascular disease. Generally young, otherwise healthy people that come up with this, random cardiovascular diagnoses that are generally, they're referred to a cardiologist. The cardiologist will work them up with an echo and diagnose this, but it's generally not severe enough to medicate or whatever, or the patient responds poorly to medications. So it's just kind of there hanging out on their, diagnosis sheet. They report dizziness, fatigue, need to lay down at certain times or in a postprandial state. Remember, that's a big clue for you. They drink a ton of water, but they conserve it. So this is the patient that you can sit with. I always am trying to get more fluids into my patients. When I'm sitting with my patients, we do hour-long appointments. I'll be frequently refilling their water, refilling their tea or whatever. And most patients have to go pee at some point during the visit or soon after. These are the patients that will throw back the liquids and they never have to pee. And it's because they are depleted in terms of their volume. Talk about that on the next slide. They're generally bendy. These are the people that are good at yoga. They're not necessarily great at building muscle, but they're really good at being bendy. They have a lot of fear, right? And that's because of the compensatory adrenergic overdrive state that is tissue laxity and the compensatory effects of the sympathetic nervous system cause. And so they generally are going to have that is the reason for their disrupted circadian rhythms. They're never going into a parasympathetic state. GI symptoms due to parasympathetic withdrawal and other reasons. And these are the patients that are frequently diagnosed with anxiety, but benefit minimally, if at all, from SSRIs. Generally, they're better with anxiolytics and propranolol, right? And the propranolol prevents that tachycardic state and the sympathetic overdrive that comes with it. So this is just a review of mechanisms of POTS, things that you might look for in terms of local symptoms, global circulatory symptoms. This is kind of a useful mechanistic graphic. And so our goals for this patient, first and foremost, if there's blood volume missing, which there often is because of the effects on the renin-angiotensin-aldosterone system that COVID causes, we want to restore that blood volume very simply with water and minerals. We want to mimic as much as possible the renin-angiotensin-aldosterone system, which we can do through physical maneuvers and we can do using some botanicals. We want to restore sympathetic tone. We want to restore circadian rhythms, and we want to restore cardiac function through tolerable, the emphasis being on tolerable exercise. Right? These patients are constantly being told they have to get up and walk around and exercise, but they literally can't because all hell breaks loose when they stand up, and especially when they stand up and exercise. So the mechanism of actions that we're talking about here, 70% of POTS patients are reported to be hypovolemic with an average 13% volume deficit. That's pretty significant. So not enough volume means lots of compensation from the sympathetic nervous system, and also not enough blood getting to the brain and the tissues above the heart, essentially. Viral entry of the central nervous system via ACE2 receptor leads to dysfunction, and also the other organs that express the ACE2 receptor leads to dysfunction of the RAAS, leading to lower plasma volume and higher angiotensin II levels as a compensatory mechanism. Low blood volume causes baroreceptors to trigger tachycardia, and elevated angiotensin II levels come from adrenal and other organs kind of kicking in, causes a sympathetic adrenergic activation, fear and anxiety, and over time, these are the patients that will come up with like diagnosable hypertension without cardiovascular disease. No other like cardiovascular risk factors. They don't have diabetes, they have normal blood sugars, lipids look normal, blah, blah, blah. But they have this over hypertension, right? And it's compensatory. So you can treat it for sure. Sometimes make the patient feel better, but it doesn't undo why the hypertension is happening in the first place as a compensation mechanism. This last piece, generally because of hospitalization, so this more applies to the hospitalized patients, but also sometimes these symptoms get so bad that these patients like literally cannot stand up. They have to spend a lot of their time in a recumbent state. And so what that leads to is deconditioning, meaning that the heart literally shrinks, right? And so between that and not enough blood volume around, we get this low stroke volume, and we have severe challenges getting enough blood to the brain, causing this compensatory reactions all the time. And so if in patients that get echocardiograms or they get MRIs of their brains, you'll see this in the imaging. They will remark upon how there's this general atrophy of the brain, right? That's not specific to any one place, but of the whole entire brain. Hypovolemia support management. These people need a lot of water, 3 to 4 liters a day. That's quite a bit for most people. Most people are drinking nowhere near that. We want to replete their minerals. And so good old-fashioned table salt, sodium chloride, up to 10 grams a day. There are patients that are good for this. They can take as much salt as you can throw at them. Remember, if you are prescribing sodium tablets, you have to back up sodium tablets with the other electrolytes so that the other electrolytes don't get displaced, particularly potassium. So you want to use supplemental potassium, calcium, magnesium as well, right? And so I like to prescribe along with salt tablets. Another capsule of electrolytes is taken in conjunction with the salt tablet. Compression stockings can be really useful for these people. They have to go to the waist to do anything because you're trying to get all that venous blood back up to the heart. And abdominal binders, these are really useful for literally standing up and moving around. We want to sleep with the head elevated over the heart because that encourages blood volume expansion. And we want to avoid heat, strenuous exercise in a standing position, and emotional stressors if at all possible. This is a really excellent self-care table that I like to provide patients with. And it essentially gets into some of the things that like a lower body compression, counter pressure maneuvers, kind of artful mechanistic ways that we can get blood back up to the heart. And it's really important for these patients that they have some sort of conditioning plan that doesn't make them more sick and doesn't exacerbate their symptoms. So generally, exercise needs to be done in a recumbent state, at least to start. So that's like a reclined bike or, rowing as they work up to it. Floor Pilates, swimming is really great for these patients if they can do it. You want to do a slow introduction, not push past tolerance. And so the author or the professional that's written the most about this is Levine. The Levine protocol is frequently used for POTS and EDS. And so there's kind of statistics from a study that Levine put together that I included for you here. But if you're treating this patient population, I highly encourage you to read that study. So there's lots of potential pharmaceutical interventions here. Beta blockers, especially used in this patient population because they control that tachycardia. Propranolol tends to be the best tolerated because it can be dosed in small doses and it can be administered preventively for before the patient stands up and is trying to do anything to prevent that adrenergic overdrive and all that comes with it. The rest of these are mentioned in the literature, but they're not being used a ton. One of the things that was interesting to me was fludrocortisone, which is a mineralocorticoid agonist. And you'll see this prescribed for patients with Addison's disease because, adrenal glands are not working, they're not producing cortisol, they're also not producing aldosterone. And so fludrocort is prescribed for them. And you have to be monitoring always for hypokalemia with whenever you're affecting our renin-angiotensin-aldosterone system sort of intentionally. So the literature on pharmaceutical interventions repeatedly says, like, watch these patients for side effects because they're generally very, very, very sensitive, this patient population, and that the benefits often don't outweigh the side effects that happen with medications. And so this is where simple interventions like water and minerals, very, very helpful for this patient population. Also helpful is like our knowledge as naturopathic doctors of the adrenal glands and the things that they do. So these patients generally have something weird going on with their cortisol, their adrenal glands. Either they are like off the charts high because they are spending a ton of time in a sympathetic state. So they're just like chronically pumping out tons of cortisol to try and get cortisol and aldosterone to try and get blood up to the brain and, to poorly perfused tissues. And or if they've been at that long enough and their adrenal glands have been in overdrive for long enough, they're going to have no cortisol at all. And so in either case, essentially the mechanisms of action that we're going to talk about are going to be helpful, right? So in one case, we want to discourage that sympathetic dominance by helping the body. In the other case, we want to support adrenal function if it's missing, right? Because that will increase our production of endogenous aldosterone. So our minerals and B vitamins, very helpful for these people, like your adrenal cocktails, the people that are like constantly craving salt, like they need salt, right? They just need salt. B vitamins, the adrenal glands love them. Adaptogens and GABA are really helpful for these patients to decrease the adrenergic sympathetic fear response. And then glycyrrhiza. So glycyrrhiza in the appropriate patient that has not kicked over into overt hypertension yet, right? Because of course, licorice contraindicated there. And if you're supplementing potassium, because just like the mineralocorticoid agonists, licorice can deplete that potassium. But glycyrrhiza has active constituents that can sort of mimic our renin-angiotensin-aldosterone system. And so, via interplay with cortisol also increases our arterial tone and aldosterone output. And so there's a graphic here of a nephron and licorice having a potential direct effect, still up for debate in the literature, on our mineralocorticoid receptor, but in any event, sort of mimicking our renin-angiotensin-aldosterone system and causing sodium retention and potassium secretion. And so useful if that system's not working, right? And useful in this patient population. The other problem is you want to restore that parasympathetic tone, both for like encouraging that rest and digest, mostly to encourage that rest and digest state and get the person out of this fear response. The vagal efferent, so you can do that directly by engaging the vagus nerve, right? So vagal efferent fibers innervate the heart, the lungs, the gastrointestinal tract. They support circadian rhythms. They regulate cardiac, respiratory, digestive functioning. Really useful, big, huge nerve to engage, right? And fortunately, somebody's figured out that if you put an electrode onto the tragus, we can access the auricular branch of the vagus nerve that way. You hook it up to a TENS unit. You can or you get a vagus nerve stimulator, one of the more expensive ones. You can access that vagus nerve and harness its capabilities. So the TAVNS, lots and lots of literature out there on this. It's safe and affordable therapy that can be performed at home. Many of my patients use this. It directly activates the nuclei of the brainstem. enhancing production of catecholamines and GABA, so inducing that relaxation state. So I really love to have patients do this before bed. It's been shown to enhance vagal tone as measured by heart rate variability. And the specifics for neuroplasticity in the literature are right here. If you want to advise your patients, this is just the most frequently used thing. Some people respond better to different parameters. And actually, there's different parameters for pain, and there's different parameters for other things. These are the specifics for neuroplasticity. And this is where we can access the vagus nerve. I like this slide in particular because it incorporates acupressure points that our acupuncturist colleagues are frequently using. Kudos to you guys. So our clinical takeaways for this patient, don't underestimate the simple interventions, right? This is a complicated problem, but simple interventions really take you a long way with this type of patient. So we have our water and minerals, heavy on the salt, back it up with calcium, potassium, and mag. We want to support adrenal function broadly, right? Understand what the adrenal glands are doing, whether they're still working or not, support accordingly. And with licorice to mimic aldosterone. Contraindicated hypertension, remember that. We want to recondition the heart with tolerable exercise, starting at low intensity. We want to use our transcutaneous vagus nerve stimulator. And we want to, if using medications with these patients, you just want to watch for aggravation. And these are the patients that need like a lot of validation because that sympathetic fear-induced state tells them that they are dying constantly, right? And it is a horrible, awful anxiety that they cannot get away from. And so they just need to be told what's happening. They need to be told what's happening with physiology. And that if we can shift the physiology over, that fear factor does go away. And so that can be really rewarding with these patients. And so here we go to our mast cell activation patient. So this is our ongoing neurotropism, which again means just ongoing viral invasion. They can't clear the virus because of how their immune system is set up. The mast cell active patient, just like in any infection, not just COVID, really was highlighted by COVID, but in any infection, I don't care if it's viral or if it's tick-borne or if it's, parasites or whatever, they can't clear it because their immune system's natural response is mast cell dominant. So histamine dominant, other like pro-inflammatory types of dominant, massive effects on tissue, doesn't really clear the virus or kill the virus or the infection, right? And in fact, some of the mechanisms of action really encourage that infection to stick around. So the ongoing immune response leads to ongoing tissue destruction and ongoing dysfunction. And the virus is still hanging out there in our long COVID patients that have mast cell activation as well. So these patients continue to display symptoms of viral infection, right? That's how you know the virus is still there. They've got temperature regulation issues, they've got myalgia, they've got that constant feeling of like coming down with something. This is the patient that has sort of like the migraine-y, like pain symptoms really forward. They talk about pain at the base of the skull, kind of coat hanger pain with distribution down the neck and across both shoulder blades. These are the patients that have small fiber neuropathies. Their like pain sensation is kind of turned up for some of those reasons that we saw with that mast cell activation previously. Increased pain, sensation via prostaglandins and a couple of other things. These are the patients that will periodically like not be able to move things like their bodies, right? They will have paroxysmal paralysis because the nerves are so affected by inflammation. They have difficulty with motor functions, walking, talking, breathing. These are the patients that are like, you have to sort of like lean back when you're talking to them because they're really overstimulated. And that's because the effects of histamine on the brain. They're loud, they're frequently diagnosed with ADD. They might benefit from ADD treatment for sure, but it's not going to correct that neuroinflammation that's causing it. They're generally going to have a histamine history when you start asking about allergy symptoms. They'll usually have a lot there. And so our goals here, we want to dislodge the spike protein. We want to help this patient actually clear the virus, dislodge the spike protein from ACE2 receptors and NACH receptors. It's not as easy as putting in antivirals. You actually have to like break that bond. We want to restore cholinergic output. to restore, nerve function and calming of the nervous system. We want to calm down our mast cells. We want to use immune modulation tools and anti-inflammatory tools. And so our persistence of COVID stimuli in this patient group, like we said, is a big problem. And so viral particles are found in the gut, lymph nodes, hepatic tissue in 60% of patients with long COVID 1 year post-infection. And this is generally going to be your mast cell active patients, right? Because they're not clearing the virus. They're too busy making an overblown histamine dominant immune response. The free-floating spike protein can cause its own troubles, right? Can upregulate local immune system pro-inflammatory type issues. And so we have to clear it out for these patients. So autoimmunity is also very problematic in this patient population. These are the people that are prone to autoimmunity in general. They tend to display autoantibodies to ACE2 receptors, adrenergic receptors, muscarinic receptors, extracellular proteins, coagulation factors, and endothelial cells. And 75% of POTS patients are positive for this alpha-3 acetylcholine receptor antibody, right? So acetylcholine receptor is affected in many ways in the pathology. Autoimmunity, again, thought to be mediated by molecular mimicry and mediated by mast cells. And so we want to start to think of artful ways that we can divert our residual spike proteins from our ACE2 receptors. Methylene blue is particularly good at this. Interferes with the ongoing reservoir of viral infection by inhibiting entry of the virus through various mechanisms. And actually, I'm going to skip right to my graphic here. Yeah. I'm going to skip right to my graphic here. So these are all the ways. MB stands for methylene blue. Here's the SARS-CoV-2 spike protein trying to enter. This is particular to this graphic is particular to a pneumocyte, but really behaves the same way at any cell type that expresses that ACE2 receptor. So methylene blue, through its transport of zinc into the actual viral body, can inactivate it here. It can also interfere with the formation of the lysosomes the virus uses to enter. It can also interfere with the viral unpacking and uncoating and the sort of unpacking of its own RNA. It can interfere with RNA replication. And so it can prevent up to here, causing apoptosis of our cells. So from there going down, if you've used methylene blue during acute infection, you've prevented all this upregulation. If you're using it during long COVID, you're preventing this like mini cytokine storm from continuing to occur. And so you don't get that downstream upregulation of, that happens in this patient population because of persistence of the virus. Oral dosing, this is how I do it. You can do it differently. I start low for virtually everybody, and that's because methylene blue can also act as an antimicrobial. And again, with my very, very sick patients, we want to go low and slow. We don't want to like rock the boat too terribly much. Mostly what we're trying to do is get a little mitochondrial stimulation and discourage spike protein binding. So these are the dosings that I use. And then if you have immediate poor reaction, you have to recognize that it's basically a die-off effect. It's essentially a Herxheimer reaction. So the dose should be decreased, and then you got to upregulate your anti-inflammatory mechanisms of action. And so I really debated whether or not to include this clinical thinking in this presentation. But because it is such a promising therapy, and because of not just anecdotal reports, but research studies, which I'll show you on the next page, I cited one. There's lots and lots and lots of them out there. Nicotine is as it turns out, very useful therapy in this patient population. And that's because it binds to the NACH receptor that, again, mediates sort of all this cholinergic output from the brain with 30 times the affinity of ACH, right? So if there is a spike protein bound there, nicotine will kick that spike protein off. And so this is where this proposed mechanism of action comes from. So I really hate to say this because I, don't approve of smoking or anything at all. But having said that, the nicotine property of smoking apparently is protective against, the more pro-inflammatory immune responses. So a cohort study of 8.28 million participants showed lower odds for COVID-19 infection in the first place and ICU stay in association with smoking. So smokers actually had better outcomes, not in terms of lung stuff, actually. Smokers, not in terms of lung stuff, but in terms of the severity of infection and their clinical presentations. And that's because of the anti-inflammatory cholinergic response that occurs when that ACH receptor is bound by nicotine. I hate to say it, but it seems to be a thing. Studies date back several decades in applications for neurodegenerative diseases like Parkinson's disease and like various types of dementia and Alzheimer's. Application of nicotine continuously, which of course we're not going to recommend that our patients take up smoking, right? We're just not going to do that. If we're going to use this therapy, we're going to use it in the smallest possible doses, but we have to use a continuous application. And that's because we don't want an on-off effect. We want a continuous application effect. And when we use this continuous application effect as in a patch that's changed daily, we get, instead of what you would think would be downregulation of nicotinic acetylcholine receptors, we actually get upregulation of high affinity nicotinic acetylcholine receptors. So this is why smokers often will start out, 1 or 2 cigarettes a day, but then they have to keep like smoking more to attain the the first sorts of, or to attain the benefit, right? And the benefits compound that they experience, other than the damage to their lungs, the benefits compound because they're upregulating these high affinity receptors. So functional improvement of vigilance, locomotor activity, cognition, respiratory function, cortical blood flow, EEG studies, pain resilience, cardiovascular and GI regulation, animal studies. And then something that was reassuring to me is that a 2007 study of Parkinson's patients showed no side effects with low dose administration. For our non-smokers, that's going to be a 7 milligram patch. That's the lowest. It's the lowest nicotine patch that's made, and these are available over the counter now, so your patients can go get them. And no residual addiction. So you use this therapy if you are comfortable with it. Totally understandable if you're not. But you use this therapy for the shortest amount of time that you need to. And apparently, like according to the literature and some of the anecdotal reports that I've heard, I have yet to start experimenting with this in my practice. You can get regression of symptoms within days. It really is truly amazing in certain patients. So if you're interested in this therapy, this is a pretty good article, and it cites several other articles that will be of interest. And is the post-COVID-19 syndrome a severe impairment of acetylcholine orchestrated neuromodulation that responds to nicotine administration? And it follows several long COVID patients, their treatment with nicotine patches and their regression of symptoms. Very promising. Just going to say that again. Understandable that this would be controversial. So to your comfort level. You can also, obviously in this patient population, they're reactive to a lot of things, and many, many people are going to be reactive to nicotine patches, nausea, rashes, et cetera, et cetera. So you can also use transauricular vagus nerve stimulation, GABA, other things to restore that cholinergic output. Also useful. You can, I put the parameters here for migraine and pain syndromes, most common settings. So also useful in this patient population. And so in terms of calming down our mast cell reactivity, obviously that is a really good goal, because you can calm down the mast cell reactivity, you're going to calm down a lot of the ongoing inflammation, destruction of cells, remodeling of tissue types, et cetera, et cetera. These are the pharmaceuticals that are frequently used on the mast cell activation website foundation. The first thing that you see is everybody with mast cell activation gets, histamine blockers. Generally, it's cetirizine, 10 milligrams twice a day. And they also get H2 blockers as famotidine, 20 milligrams twice a day before meals. Optional H3 blockers, that's generally hydroxyzine, crosses the blood-brain barrier. Small doses work well if they don't put the person to sleep for an anxiolytic effect. Generally, people that have a lot of histamine going on, they can take this stuff till the cows come home. It'll never make them sleepy. It may have a histamine discouraging effect and an anxiolytic effect. Larger doses are prescribed for sleep. Histamine blockers, I don't use them a whole lot, quite honestly. Sleep stuff sometimes can benefit, but they have variable effects on people. And not to mention, this is a very sensitive population. These are people that are sensitive to like food dyes, and they're sensitive to fillers. And it's, unless you're going to be compounding these things, which admittedly I do for some patients, they're generally going to be reactive to the things that are in the histamine blockers. And so these are patients that respond very, very well to herbs. And so, the other things that are mast cell stabilizers in the pharmaceutical realm, platelet activation, platelet PAF inhibitors, platelet activation factor inhibitors like aspirin, mast cell stabilizers, cromolyn sodium and ketotifen. Cromolyn sodium pertains mostly to mast cell activity at the gut level. I find cromolyn sodium really useful in pediatric populations. And then ketotifen can be useful in this patient population. But there's big downside to ketotifen, which is that it makes people tired and it makes them a little depressed. It has this sort of like flattening effect. Generally, that's because a person that's hopped up on histamine, a lot of their neural system function is run by histamine. That's what animates them. That's what makes them interesting people. That's what makes them artists, et cetera, et cetera. You shut that down, you get this flattening effect on the personality, right? So use ketotifen in the lowest doses you can possibly get away with. Dosing variable depending on patient needs. You also have your leukotriene inhibitors like montelukast. This is an area that phytonutrients really shine, right? And so if you like all the herbs that you think of that are like mast cell stabilizers, anti-inflammatories, antihistamines, use those. They work so well in this patient population. Luteolin, quercetin, genistein, EGCG, all in the flavonoid category, all stabilize mast cells. L-theanine, excellent anti-inflammatory for the brain, right? It works via mast cell stabilizing, and also as a cortisol antagonist. PEA, useful in this patient population as an analgesic, and as a blood-brain barrier sort of stabilizer again. Has an analgesic effects, binds to the endocannabinoid receptors. Nigella sativa or black cumin, super useful as a mast cell stabilizer, but also helps out with mitochondrial function and decreasing reactive oxygen species. All these things, like, I mean, you can find endless amounts of research on these things, fortunately, right? And so this is an area where like plant medicine really shines here. Love this picture because it really shows off some of my favorite herbs to use. Astragalus, the camellia, humulus, passiflora, all these beautiful herbs. Use them. They all have these histamine stabilizing properties, mast cell stabilizing properties. I also really love artemisinin in this population. And one of my favorite things to do when I'm preparing for a presentation like this is to actually dig into the mechanisms of action and explain why these herbs that we kind of use on a day-to-day basis work so well. So artemisinin increases the CD4 to CD8 ratio, which increases the COVID antibody production. And decreases the production of pro-inflammatory cytokines like your prostaglandins, your TNF-alpha, your IL-6, your IL-10. And so you avert the immediate cytokine storm of like an acute COVID infection, but also the long-term mini cytokine storm of a long COVID infection. And like these are the goals that you're trying to accomplish in this patient population, right? You're really trying to get that immune response to be more effective, less inflammatory. or less destructive, I should say. It also has a bonus of, in vitro at least, can prevent spike protein docking with greater efficiency than hydroxychloroquine, right? So one of the drugs that was initially used in COVID. It also has great ability to control other secondary infections, which can be so problematic in acute COVID presentations. For chronic dosing, I like to use 100 to 200 milligrams twice daily alone or in combination with berberine-containing products. So berberine is another herb that I really like for this patient population. It's antimicrobial, but immunomodulating. And in general, for this patient population, you want your immunomodulatory antimicrobials, right? So berberine, astragalus, artemisinin. You want to be thinking less about echinacea and other more direct immune stimulants. Low-dose naltrexone, great for this population because it helps to upregulate growth of tissues, wound healing via that reflex mechanism where it upregulates opiate endogenous production of the opioid growth factor. It modulates glial cells and peripheral immune sentinels by blocking toll-like receptor 4. So we get this reduction of pro-inflammatory cytokines. Generally, very good for improving mood, right? Very, very good for improving mood. Quality of life enhancing. And, you know, for what it's worth, it makes these patients a lot easier to communicate with and get along with when they're in a better mood, right? And I think that has therapeutic value in and of itself. Of course, we have to have caution with our SSRIs because some patients will show up with a serotonin syndrome because of upregulation of serotonin. And then obviously we have to have caution with opiates and pseudo-opiates losing their effectiveness because the downregulation or the blocking of opiate receptors. Clinical takeaways for this patient. This is the allergic mast cell activation patient that hasn't cleared the virus, right? So we have persistence of unnecessary immune activity because of the ongoing presence of the virus and this feed-forward cycle that's ongoing until you figure out a way to interrupt it. We want to focus our immunomodulatory techniques, whatever you like in that sense, herbs, LDN, whatever you would generally use. We want to calm down mast cells, reduce histamine activity with tools that are predictable for you and tolerable for the patient, right? This patient population reacts to a lot of stuff, right? This is the patient population that's like, I can't take anything, you can't give me anything, but still get me better. Okay, so we need to contextualize what a side effect is in this patient population. And we need to say repeatedly, most things are going to cause a reaction for you when you introduce them. This is why we want to introduce a little bit at a time, ensure that you're not getting worse, you know, for a good reason, but introduce a little bit at a time, slow, you know, small, minuscule amounts. Generally, that immune response and initial reaction will get deconditioned, right? So if you're using something that's safe, it's not a medication, it doesn't have, you know, known side effects, you know, generally you can get this into the patient. If you have patients, you have to be very patient with this patient population. And they have to be patient with you. And a lot of explaining has to happen. So we want to offer perspective on side effects for sure. And so that's all I have for you today. If you'd like to get in touch with me for questions, you can always do so through my website, New England Naturopathic Health, Naturopathic ME. Lots of great information here in our many pages of references. This is a lot of blood, sweat, and tears went into the collation of all of this research. So I encourage you to take a look at it. Thanks so much for watching this today. Don't forget to fill out the evaluation so you can get CE. And take care, everybody. Bye-bye.